Okay, so let's see if we can finish up this thing. Maybe we won't have time to do the heart. We'll save that for the next time then. So moving on. So there's two things that we'll talk about, which is hyperemia versus congestion. When you have more blood that is flowed to the area, that's called hyperemia. Okay. When there is a blockage of the blood flow, this backup, that is known as congestion. So what's the difference? A hyperemia then, it seems to be more red, and that's active, and congestion is very passive. So one way that you can do the demonstration of hyperemia is well, like that, right? And you see that area will be like red. That's mean there's more blood flows to the face. That's hyperemia. Um, and congestion, we already saw that if you have left side heart failure, for example, blood is congested. Okay, and here's it shows you. This is considered chronic congestive, chronic passive congestion. And typically, if you have right-hand side heart failure, then that means that the blood cannot, the venous return cannot go to the right-hand side, right? And if the blood cannot go to the right-hand side, what happened to that blood? Well, that blood is going to go backward, right, where it comes from, which is basically inferior vena cava or superior vena cava, right? In fact, if the right-hand side heart failure, you can see probably the jugular vein is probably distended, right? Or the inferior vena cava will get gorged with blood, but you can't see that. But what happened at that is that it's going to get back up through the hepatic vein, which then it goes into the liver. And then the liver, you can get congestions in the liver. And typically, when you have congestions in the liver, you get this pattern here. It's called a nugget pattern. And little bit about liver lobule. And liver lobule, it has this area here, like a hexagon, another hexagon, another hexagon. So this area here is known as the portal triad, which means it has your hepatic artery, hepatic portal vein, and the blood, hepatic artery and hepatic portal vein is actually brings the blood together and it pours into this area known as the sinusoid. Okay. So so you might get a liver lobule that looks like this. A liver lobule that looks like this. And a liver lobule that looks like this. And here's a central vein. Here's a central vein. Here's a central vein. So a little bit about the liver is that they're hepatocyte that is sort of like lining, like this. They're radiated from the central vein, like this. And so what they do is they actually filter the blood. And these are hepatocyte that stays here and it filters the blood. And so over here is this portal. This will have your hepatic artery, right, which bring oxygenated blood that has come off of the celiac trunk, okay? And then you also have your hepatic portal vein. So hepatic portal vein is actually receive blood from the portal vein, which is takes blood in the superior mesenteric vein, which has rich in nutrients. And actually those blood are mixed in here. And these right here will get filters it filters your blood, and then it goes into the central vein here, and then central veins then will then bring the blood out via hepatic vein. Okay. And hepatic vein will bring hepatic vein, and hepatic vein will bring blood into the inferior vena cava, which is bringing into the right atrium. So whenever you have a backup, then it goes in here and here and here, and then the patterns of that goes out. So in the lung, in the liver, you might see the nug pack, for example. Later on, when we do talk about the liver pathology, is that because this area here bring oxygenated blood. So whenever you have, let's say, there's a blockage or in the hepatic artery, for example, which area that most likely going to die first is usually around the central vein. Okay, it's because they're further apart from this area. Cells that is near this right here will get its oxygens and nutrients, but you go further away, those central veins here, they're going to die because they're not going to have a lot of oxygens and nutrients. So that's the general idea. And of course, right hand side heart failure with these congestions to do in the liver, congestion in the liver, you can see this nutmeg pattern. Okay, yeah. So congestion again this is a passive process. Most likely this blood also, it's deoxygenated blood, so you won't feel as hot. Whereas if someone hit you in the face and get hyperemia, that area hot. So, that's more redness and hot. So it's hot versus cold, for example. All right. Now, within the blood, there's a three mechanism, which we call this to help if you have a nick in a blood vessel, right? If you have a nick in a blood vessel, you're going to lose the blood volume, right? And you lose the blood volume, your blood pressure will drop. So there are three mechanisms that allow the blood to stop flowing out, if you will. Okay, so this process is known as hemostasis, and what they call it this is has involved in three different processes. One is endothelial cells. Okay, the other one is platelet, and the other one is known as coagulation. The endothelial here, sometimes people refer to this as vascular spasm. And that's usually is the first thing that you see, and that is if you have a nick in the blood vessel, that area right under spasmodic contraction, for example. Okay. That's involving the endothelial cells. The endothelial cells forms as the inner lining of the blood vessel called tunica intima, and it's a nice continuous line. It's very smooth, right? So the red blood cell, white blood cells, everything flows smoothly. Whenever you have a damage in the endothelial cells, it's going to create a rough surface, if you will. Okay? Things that normally are not supposed to be in the blood, like on the outside of the blood. If there's a nick in the blood vessel, now it's presented inside. One of the factors, thromboplastin, for example, normally it's supposed to be on the outside, but if it's on the inside, then suggested that you have a damaged endothelial cell, right? And then you have your vascular spasm. Platelet plugs, so we have a nick in the blood vessel. The numbers of platelets is important. Typical numbers of platelets should be somewhere between 200,000 to 400,000 per microliters of blood. And this is a normal number. Of course, you have lower than that, like thrombocytopenia, you're going to have bleeding disorder. And likewise, another way that seems to take longer time to react, this is known as the coagulation. The coagulation has two different processes, in fact. So coagulation. What is the coagulation? Coagulation refers to is the coagulates us to let's say to form clots. Okay. Where do clots come from? Clot is basically numerous strands of fibrin. Okay, so you get fibrin strand, fibrin strand, fibrin strand like this. All that is formed clot. Okay. So the key word is fibrin. You have to have these formation of fibrin. And they stick together and it forms this is clot. Now, fibrin comes from fibrinogen. Okay, so fibrin come from fibrinogen. Now, fibrinogen is an inactive, right? It's not active yet. Fibrin is the active. So if you had a lot of fibrinogen, they won't stick together. But if you had a lot of fibrin, they stick together and form clot. So how do you convert? Where does fibrin come from? Well, fibrin comes from fibrinogen. And how do you convert fibrinogen to fibrin? There's an enzyme called thrombin. So thrombin is an enzyme that converts fibrinogen to fibrin. And where does the thrombin come from? Well, thrombin comes from prothrombin. Right? So you have your prothrombin converted to thrombin. Right? So the whole idea here is this. You only want to make clot when you need it. And when you need it, when you have a nick in a blood vessel, that's when you want it. You don't want to make a clot when you don't need it, because that ear formations of the thrombin is known as a thrombus. Okay? So you don't need it, and you make this clot is known as the thrombus. And thrombus is pathological, it's a disease. Okay, a thrombus can move around, and it moves around is known as an embolus. And an embolus can clog in a small blood vessel, then it can lead to an embolism, for example. So embolism is anything that is irregular, that's moving around. Embolism, sometimes you can say, oh, it's air embolism. I mean, that air is in the blood that is trapping somewhere in the artery. That's called air embolism. Particularly people who has the bends, or when a diver who descends from the depth too fast, nitrogen is actually bubbling out of his blood. We can talk about that next time if we have time. And then you can have air, and air can get trapped in the blood in small artery. It's very painful. So an embolism can caused by, some fetal tissues that got into the maternal blood that is traveling around. All of that. So when we talk about a thrombus, which is a formation of clot when you don't need it, that's pathological. So to ensure that you only want to make the clot when you need it, there is actually a two-regulated mechanism that leads to blood coagulation. It's called the intrinsic factor and the extrinsic factor. What's the difference between the intrinsic factor and the extrinsic factor? When we talk about the intrinsic factors, the intrinsic pathway will require factors that is already in the blood themselves, hence the name the intrinsic. Okay, it takes longer to activate, between a minute and a half to 2 minutes for it to activate. The other pathway is called the extrinsic pathway. It's much quicker to act. It's like 15 seconds or so. You can activate it. And extrinsic factor will require a factor which is outside of the outside of the blood, okay, which is the thromboplastin or factor 3, if you will. Okay, so we're here. And then if you want to talk about the intrinsic, the extrinsic pathway, does it say here? It doesn't say. Okay. All right. So needless to say is this, you know that thrombin convert fibrinogen to fibrin. How do you activate thrombin? You need thrombin activator. Okay, thrombin activators which is actually convert prothrombin to thrombin. And how do you activate it? The activator, you need factor 10. So factor 10 is the most important one. Okay, factor 10. Factor 10. And that's where the two pathway is merged. Okay. So you can either activate this, the factor 10 through the intrinsic pathway, or you can activate via the extrinsic pathway. And the extrinsic pathway will require will require factor 12 and factor 3. No, sorry. We require factor 7 and factor 3. Whereas the intrinsic pathway, you start with factor 12. Okay. You activate factor 11. You activate factor 9. You activate factor 8. And then you activate factor 10. And that's the common pathway. Melanie, you have a question?
Hello.
Yeah.
Yeah, so you're saying that the intrinsic pathway requires factor 7 and 3, or the extrinsic pathway?
Extrinsic pathway.
And the intrinsic is factor 12.
12, 11, 9, 8.
Okay, thank you.
I thought I had it here somewhere. Okay, no. All right, that's fine. Okay, so the 3 going back again. Shamika, you have a question? Shamika?
Yes. Yes. Yeah. So only for factor 10 is only for prothrombin to convert it to thrombin?
Yeah. But factor 10, starting from factor 10 is the common pathway.
Common pathway.
Yeah. Okay, so here just shows you just diagram the 3 stages that is needed for hemostasis, which is we'll call it the vascular spasm that involve in endothelial cells. You get your platelet plug, and then you get your coagulation. Okay. So here it tells you that the ways that you can tell whether the intrinsic pathway or the extrinsic pathway is defective. Okay. And this is just a way for us to tell you that when someone who has a delay in blood coagulation, right, you want to find out whether it is the intrinsic pathway or the extrinsic pathway. And your book is kind of, your book is wrong in this way. That's why I put the X. Okay. This slide, they say, is wrong. but the next slide is correct. Okay. And that is, um, if you want to measure the extrinsic pathway, is basically is involving tissue factor, and tissue factor is factor 3, by the way. Okay, that's part of the extrinsic pathway. That's a the prothrombin time. Is that's actually what you do. Okay, and the partial thrombin time is the you can say here is the intrinsic pathway. Right. So if you look at this slides over here, you can see that here. So prothrombin time and partial thromboplastin time. If of course both of these again, if both of these is defective, abnormal is delay, right? Then that meaning that it is usually like factor 10 onward. Right? So if they're normal, coagulation functional, everything is normal, that's no problem. If both of them is abnormal, is the common pathway. Common pathway is from factor 10 downward. Okay, so, but if the partial thromboplastin time is the abnormal, then it is the intrinsic factor time. If the prothrombin time is abnormal, it is the intrinsic pathway, the extrinsic pathway, which means require factor 7 and factor 3. Intrinsic pathway or pathway that require factor 12, 11, 9, and 8. Okay, is that clear? No. Clear? Maybe? Anyone have a question? Any question?
I do.
Okay, Randy? No, Randy got it. Who has a question?
So, Shamika, I have a question. So you
Mhm.
said for if they both are normal, then it has to be something wrong with factor 10 downward.
No. If both of them normal is normal, that's it. That's your positive control. It's both, it's abnormal.
Okay, abnormal.
Abnormal, yeah. Then it's the common pathway. Right? That means factor 10 downward.
Okay. Oh, okay. See.
Yeah. Now, if it's the partial partial thromboplastin time is abnormal, that's the intrinsic pathway. Okay, and it's the prothrombin time is abnormal, it is the extrinsic pathway. And the extrinsic pathway require factor 7 and factor 3. In fact, factor 3 is known as thromboplastin, which is factor 3. And then factor 3 normally is not found in the blood, is actually outside of the blood, outside the blood vessel, that is. And so when you have a damaged blood vessel, the cells inside the blood start to see factor 3. And what seizes factor 3 is then triggered this cascade, they call it the extrinsic pathway, which leads to the activations of factor 10, which leads to the activations of thrombin, prothrombin activator, and then thrombin. Is that clear? Okay, good. All right, let's move on then. So hemorrhage is basically when you have a nick in the blood vessel, you're losing the blood. Does anybody know what's the condition cause? What do we mean by hematocrit? Does anybody know what hematocrit is?
Hematocrit's the concentration of red blood cells in your blood.
Yes. So what is the normal hematocrit? No, it's not blood volume. It's the concentrations of red blood cell relative to your blood. Right? So they say if you take your, say 10 mLs of blood, about 5 ml or 4.7 ml of that is the red blood cell part. So we call that hematocrit. So if you take it, say 1 ml, 0.5 ml, and so forth. Right? So about 47% of your blood is your hematocrit, right? Which is basically pep cell volume, which is the same as your red blood cell. The volumes of red blood cells in your blood. And then if your volume of that red blood cell is less than 47%, for example, right? Let's say 30%, for example. So we call that anemia. Right? Anemia is the red blood cell lower than its normal. Certainly, one mechanism of anemia is that you're going to have a cut in your blood vessel, right? You're losing your blood. In this case, your area could be your volumes of blood will be lower than normal. In fact, hemorrhage then leads to hypoxia, right? But in this case, what happened is that you can say that if you look at, so later on when we talk about the blood, we're going to look at the what is the red blood cell look like? How could it be anemia? Is it anemia due to iron deficiency? Is it anemia due to lack of vitamin B12, or anemia is due to destructions of red blood cell, or anemia due to hemorrhage, for example? And so you can look at the red blood cells, and it tells you, and that is depends on the red blood cell look smaller than normal, or is it bigger than normal, or be the same size. So typically, when someone's anemic, but the red blood cell has the same size, that suggests more like a hemorrhage rather than iron deficiency, or pernicious anemia, but you get large red blood cell, for example. Okay, so hemorrhage is a blood disorder, and then there could be many causes of this hemorrhage. In the case of hemophiliac type A, for example, that usually lacking factor 8, for example. Now you know that if you don't have factor 8, the intrinsic pathway is defective, and they have a delay in blood coagulation. So this is known as hemophiliac, for example. So here, called coagulation factors deficiency, hemophilia, type A or type B, type C. Yeah, it's factor 8, yes, for hemophilia A. And that's pretty common. And of course, platelet play an important role, right? And there are some people, they develop antibody that will destroy their platelet, okay? Thrombolytic, for example, lysis of the thrombocyte, which is thrombocyte, so your platelet, and consequently they have lower platelet number, so we call this thrombocytopenia. Okay, so it could be DTP, thrombotic thrombocytopenia purpura. Purpura is, what we're going to see is that a larger area of blood pool in your skin, for example. Okay, purpura. And then there are bleeding tendency, hemorrhagic diathesis. This could be part of DIC, for disseminated intravascular coagulation. Let me write this down. For disseminated intravascular because of this, it could be lead to sepsis. In some cases, could be leukemia, cancer, that kind of thing. That these people blood tends to coagulate more. And the inner lining of your blood vessels should be very smooth, right? But if you have these clots that are found on the inner lining of the blood vessel, so as red blood cell that's flowing through and hits these clots, you could just basically lysis. That's hemorrhage, hemorrhagic, the destruction of that diastasis. Okay. And of course, we saw that hemostasis is assessed by laboratory tests. If it's both partial thromboplastin time and thromboplastin time is both abnormal, where is the defect? What do you think? Is APT partial thromboplastin time and thromboplastin time? Both of them is defective. Is in factor 10. The common pathway. Okay? The answer is common pathway from factor 10 downward. And it is partial thromboplastin time is defective, and the thromboplastin time is normal, where is the defect? What do you think? Partial thromboplastin time? Good, it's the intrinsic pathway. No, in fact, no. No, not extrinsic, intrinsic. So those you put on Chris, right? So only Miriam got it right. So make sure that you know that the difference. So review that again. Partial thromboplastin time is the intrinsic pathway. Okay, so this just shows you petechia. Petechia means small blood vessel. There's this pool. And if it's bigger, it's purpura. Thrombosis. Whenever you see a thrombus and a clot is not the same. A thrombus here is basically pathological. It's always pathological. And whereas a clot is a normal clot, it's just present when you have a nick in the blood vessel, for example. A clot is formed from the classic rapid forming features of extrinsic vascular hemostasis and vascular dispensing. Okay. Thrombophlebitis and thromboembolism. Thromboembolism is typically what you often see, a thrombus that is formation and is moving around. Okay. Thrombophlebitis, basically thrombus that's moving around that can lead to tendency to bleed in this disease or irritations or of the small blood vessel. Leads to typically hypoxia, if you will. But whenever you're talking about these thrombosis, the formations of thrombus and pathological, what is the common causes of this thrombus? What is the most common causes of thrombosis? Does anyone know the answer? The common cause?
What are we going? Either high cholesterol or smoking?
Yeah, but that's not very common. What's the root cause? You remember I told you like the root cause of cancer may be DNA damage. So my root cause is more like thrombosis.
Is it platelet damage?
No, it's not. Well, no, this is basically when you have platelet damage, you got to talk about the other way, right? They don't form a clot. This is I'm talking about when they form clot abnormally. Does that make sense? So if you have a damage in your platelet, you won't form clot. You have problem. But I'm talking about you have an abnormal clot formation. What might cause that? Major cause of that?
Is that the genetic, like factor 12?
No, again, if you're missing all those cofactors, coagulation factor, you won't get a clot. I'm talking about the opposite. I'm talking about the formations of clot abnormally. Do you see the difference? The difference is that if you don't have normal clot, you're going to have bleeding tendency. And you don't have a normal clot because you don't have clot factor, factor 7, factor 8, factor 9, factor 10, etc. Right? Sometimes you can have antibody that is destroying your platelet, and you won't have an abnormal clot. You don't have a clot. I'm talking about is that this individual have clot forming. This is known as a thrombus. And this thrombus can move around, cause an embolus. Miriam, what do you think? Miriam? Miriam's not here? She left?
She's probably typing. She hasn't said anything, but she types.
Yeah, okay. All right, let me ask Christy then. What do you think the cause of thrombosis is? Christy? Also typing? Nobody? Okay, all right. The root cause of that is my computer froze. Paul, do you know Paul? Atherosclerosis, yeah, to some extent. The correct answer is endothelial. Yes, Carolina. Thank you, Carolina. Endothelial cell damage. That's the answer. Okay. And that's what causes that. You can see here. It's the endothelial injury that is really is the major factor that is contribute to this. Okay. Certainly, in some individual, hypercoagulability, and in some abnormal blood flow, stagnant blood flow can lead to this, but the major cause is endothelial damage. You can see, and typically this just shows you that here's a. Do you know this is an arteries or vein? Does anybody know? Caroline, is this an artery or is this a vein? It's a vein. Why? Oh, you're not sure. It has blood. Oh, good. So Randy, you're right. It is a vein. It's because it has valve. And this is the valve. Yeah, it has valve. And typically is when you have an endothelial cell damage, its blood is actually is pulled under that. Okay, it can lead to the coagulation, and then of course that is combined with this these other cells that you can see that. Okay. That's how it contribute to that. Okay, so the thrombus can actually move around. So an embolus in this case is going to move around. It largest on this size of the heart here. Okay. And then of course, look at the lumens going to be smaller over time. And then the heart is not going to pump the blood efficiently, for example. And also will lead to a heart failure, for example. Okay. There's a difference between a red thrombus and a white thrombus. What's a red thrombus is usually mean it's more blood in there than a white thrombus. Less, here's the original white thrombus. Red thrombus is more red blood cell, more recent. This is the white thrombus, which is occur earlier, for example, less red blood cells. That's intracardiac thrombus. All right. Okay. So shall we take a break or just finish another 15 minutes? and finish it. Yeah, typically they say more red blood cell is when an involvement of more red blood cell, and it's red thrombus. The white thrombus is less, um, not a lot of red blood cells there. I mentioned earlier about DIC can lead to damage of the red blood cell, for example, because in the lining of the red blood cell should be, in the lining of the blood vessel should be nice and smooth. But when you start to have a clot, then the red blood cells moving over these bumps, these clots, can damage it. Okay. The this area when we have a condition when you have clots everywhere called disseminated intravascular coagulation, or DIC, and DIC can cause by a number of things that you can see here. Okay, sepsis, leukemia, abruptio placenta, massive trauma, for example, can causes that. Typically, I call them. You just remember them as SLAM, as sepsis, leukemia, abruptio placenta, massive trauma, and severe allergic reaction. There are many more, but this is some of the good way to remember them. And the problem with this is that DIC not only is involved in destroying red blood cell, but that when you making a lot of clot, right, you are really using up all the raw material. You're making clots everywhere, you're using the raw material. And so then when you do need to form clot, if you have a nicked blood vessel, you do not have sufficient raw material to do it. You don't have those factors, right? So in other words, you already use up all your clot factor to form the clot abnormally, of course. So in this case, we call it consumptive coagulopathy. Consumptive means that you use up all that already. That's the problem. That's, you can say, sequela from these DICs are consumptive. And then, of course, you're going to have bleeding disorder. Okay? And as well as, destruction of red blood cell. And DIC is always secondary to something else. Usually it's these things right here. It's first that can lead to that DIC. And a very common sepsis is very common too. A lot of bacterial infections, sepsis, lead to DIC. Okay. Embolism basically is just basically a thrombus doesn't move around. That's an embolism. It can be any numbers of things. We saw that's a thrombus can move around. Bone marrow can move air, typically amniotic fluid that can move around. Tissues that can move around. This is very common in the case of the bend. In the case of the diver that ascend too fast, for example. The bend. Okay, an infarct then is basically necrotic tissue. Okay, and again, you can have either white infarct or the red infarct. And the infarct is typically because you have less blood flow to the area. There is going to be areas going to become hypoxic and become ischemic later on, and then it's going to be necrosis, and they're going to die, an infarct. And you can have a red infarct and a white infarct. And then here's the difference might be is that when you have a organs or tissue that has a lot of blood, they'll tend to be, like softer tissue as opposed to harder tissue. You're gonna get a red infarct versus the white infarct, for example. So, things like a white infarct, red infarct might be seized like in the kidney or in the lungs, for example, but red infarct. But white infarct is like harder tissue, maybe the heart or maybe the liver, for example. Okay. And usually the infarct will come result in this predictable fraction, and that is we had a blockage in the artery, leads to ischemia, and then you're going to lead infarction, which is die. So can you have an infarct without an occlusion? Can you have an infarct without an occlusion? No. Okay. Can you have obviously a question asks, can you have an infarct without occlusion? Certainly you can have an infarct without an occlusion, right? So not every, this area right here is ischemic, right? And you have an infarct here, sorry, you can have occlusion here that blocks it. Is that the only reason why this thing might die? That this area become ischemic? No, there could be other, could be, let's say there's a blood loss here. Okay. So blood leave, so then less blood flow, right? That's not an occlusion, less blood to that can lead to ischemia, right? So certainly, yes, you can have an infarct without an occlusion. Okay. An occlusion, can you have an occlusion without an infarct? An occlusion without an infarct. So let's say you have an inclusion here, but this area is normal. What might cause that? Right. There's an occlusion. Wait, how could this thing here be normal? Well, especially there are other blood vessels that feeds to it. Okay. So it can have an occlusion, but not that. So usually in the heart, you might see something called anastomosis. Okay. Okay, so anastomosis really mean that let's see, and that's what that mean is, you know, an area might be served by more than one blood vessel. So if you want one blood vessel is occluded, at least the other blood vessel can bring its oxygens and nutrients. Okay. Yeah. Okay. Where are we now? Okay, so usually white infarct occur in sort of like solid organ. You can see here, like the liver, but the lungs, that's a soft one. That's more like a red infarct. Can you have an occlusion without an infarct? I just explained to you, yes. Right? You can have an occlusion without an infarct, particularly if that area is served by multiple blood vessels. Anastomosis. Does that make sense? Okay, good. Okay, so a white infarct, we'll probably see it in more of a solid organ, right? And a red infarct is more like a softer organ. Definitely in the lungs, for example, you can see more like a more red infarct. Okay, the question. Okay, so lastly, here's a couple more slides. Okay, so there a shock within our system. Typically, there are any numbers of things that can cause us, the whole body to go into a shock, particularly, you know, less of blood flow to the areas of multiple organ failure. Okay, there's there's different kinds of shocks, but we can say, okay, hypovolumetric shock. That's the name implies itself. That means normal blood volume decrease. What is a normal blood volume? 5 ml. Okay, so hemorrhage, lose that blood volume. All right. So then you can go in hypovolumetric shock. Cardiac shock, typically if your heart stops working, then the blood won't flow. Your tissue will deprive of oxygen. You then you go into shock. Not only the multiple organ obstructive shocks. Obstructive could be basically general obstructive of one region, not too bad, but obstructive everywhere. Sepsis shock is very common too. And sepsis shock is usually bacteria infection or bacterial byproduct toxin that leads to sepsis shocks, in which you get major vasodilation everywhere. Okay, when your blood is actually, or plasma oozing out, and then you can go into shock. And typically, um, if you can say if something is mild, right, non-progressive, you can say here, there are mechanisms in our body that could sort of like adjust to that. Now, progressively, if you don't treat that, then it can lead to this irreversible stage, which then multi-organ failure. But typically, if it's mild, you can have other system that can try to um, uh, attempt to correct the damage, right? So one example would be, say, if someone is losing blood, for example, so blood volume decrease, the sympathetic nervous system can work it, and the sympathetic nervous system work on several ways. One way it could do is basically causes vasoconstriction, right? In attempt to bring up the blood pressure, because someone is hemorrhaging, the blood volume is decreased, the blood pressure is decreased, right? So you wanted to bring it up, so the sympathetic nervous system will attempt to cause a major blood vasoconstriction. Sympathetic nervous system can also increases the heart rate, right? So sympathetic is like adrenaline. And we know that when you get adrenaline output, a lot of adrenaline, you're going to get your heart rate to go faster. So another way, heart rate trying to increase so that it's going to bring up the blood pressure. To some extent, the juxtaglomerular cells, which is the cell that is secreting renin. I don't know if you guys, juxtaglomerular is a cell that's surrounding the afferents arteriole. They're the cells that secrete renin, and the sympathetic nervous system can stimulate these cells to put out renin. And we also know that the effect of renin. What did renin do? Renin convert angiotensinogen to angiotensin 1, and ACE convert angiotensin 1 to angiotensin 2. What does angiotensin 2 do? It stimulate the adrenal cortex to put out aldosterone. What does aldosterone do? Stimulate the kidney to take back sodium, and then water retention goes out. So in the non-progressive, all of these things affected, right? All of these in the attempt to bring up the blood pressure. Now, if it's basically all of these right here occur, but it, somewhat correcting, we already know the consequence. If it doesn't, it leads to this irregular, and then of course, if it doesn't, then it gets into this progressive stage. It's in between, and the progressive stages in between, then of course the cells barely surviving, right? It's getting oxygen but not as much, and skeletal muscle might undergo anaerobic respiration to build lactic acid. You might then get acidosis, and then the vicious cycle continue basically. So you get from here to here, and then multiple organ failures, and that's it, you're going to die. All right, so lastly, this slide then we showed you the similar thing that I showed you, which is different stages of shock that we saw. It could be cardiac shock, you saw it could be hypovolemic shock, it could be septic shock. So don't worry too much about that obstructive shocks, as you can see. So it's either in 3 stages that you can see that it's non-progressive, progressive, and then you can see here, non-progressive, progressive, and irreversible stage. And what happened in the irreversible stage? Multi-organ failure. All right. Okay, so that's conclusion of that fluid and dynamic. I'm going to turn off the recording now so that in the future, if you guys want to re-listen to this, you